Good morning, everyone, and welcome. Our first panel is on the topic green health. We have a very inspiring set of speakers, so I will start with introductions and introduce speakers as we go along. Our first speaker is Professor Paulo Saldiva, who is a full professor in the Department of Pathology in the Faculty of Medicine at the University of Sao Paulo. He has been researching the health effects of ambient air pollution for more than 25 years and has led several experimental, epidemiological, and clinical studies. He's a full member of the National Academy of Medicine and the Brazilian Academy of Sciences and the Meteorological Organization for Climate and Health Issues, and also a member of the Scientific Council Committee of the Harvard University School of Public Health. He has served as a member of the International Agency for Research on Cancer that evaluated the carcinogenity of ambient air pollution. He's also a cyclist and harmonica player, and we're very pleased to welcome him here to Delft. So, Professor Saldiva, the floor is yours.
Good morning, everybody. It's a pleasure to be here and a physician, a near physician. And I still practice with medical students, but I discuss the effects of urban green and how urban green has to establish a crosstalk between climate, urban climate, air pollution, but mainly with human vulnerability. Now, if science is enough or the sufficient to change things, I don't know, because we need to produce data, but also the changes incorporate values, moral values, and also possibilities and limitations, and the local characteristics of each place, including within city environability. But let's see how is the production, how much is produced in Web of Science about green and human health. You see, there is a USA, Chinese, and European. There is a symmetry because the areas are more subject to climate changes and are not producing local data. This is a demonstration. These are the paper that we published a couple of years ago, where in the upper left right panel you have the variables of air pollution, and you have the production, the output of so the levels of air pollution, and then you have the research output on air pollution in the right upper panel. A complete scene. Where there's pollution, there's no scientific local production. And you see production about malaria, for instance. It's more distributed, and diarrhea as well. So there is a mismatch in the case of diffuse risks between local production and research. Biomass burning is also a problem, recent problem. And again, except for Brazil, biomass burning in Brazil occurs, let's say, 5 centuries. But other areas of the Amazon, Indonesia, Central America, are being subjected to air pollution, to biomass burning, and no evidence of local pollution being more affected areas. And let's go also. So my first idea is that if science is needed, I don't know if it's sufficient. There is a lack of data, and we import solutions from areas that probably will not work in the scenario of the affected area. Let's see, this is a paper that a group of epidemiologists and physicists published in Lancet in 2015. How we read this paper, this graphs. This is the variability in temperature across 15 years. This is the histogram of distribution of those temperatures. In the y-axis, there is the relative risk of dying. The next day, in the day, and the following day. This is the percentile of 97%. 2.5% higher temperatures. These are the 2.5% of lower temperatures observed across 15 years. This is the relative risk of dying. And we established arbitrarily the lowest effect, the safest temperatures for the city. And you see, let's say Toronto and Stockholm, wide thermal variability, almost nowhere. So the city adapted to changes in thermal variability. So it depends on housing, clothing, social factors. Let's see New York. New York is more adapted to cold than hot temperatures. There's steepest and close to the minimum level temperature. Why? When we left Ethiopia, the humans went to the northern latitude. The challenge was adapted. And also, it's easier to light a fire than 31 air conditioning. And you see London. All the city has vulnerability to both cold and hot temperatures. São Paulo has this variation. That means that when temperature exceeds, let's say 24 degrees of temperature, 25, and gets to the hot waves, you will have an increase of 50% of mortality. That means that about 100 people die per day. All the waves as well. But every city has a different contours. Within Brazil, let's see, Recife, no, let's say Teresina, one of the hottest capitals in Brazil. The comfort zone for them is 28 centigrades, which represents in São Paulo an extreme temperature, a hot wave. For each city, there is a thermal difference. This means climatization and physiological adaptation from turbulence different situation. Let's see within city, São Paulo, temperatures across the city, the thermal gradient across city. And let's see what this is not. But let's go back to Brazil. This is a time series that followed more than 18,000 cities in Brazil with 15 years in foster populations. Who are the most vulnerable? There's the relative risk of hospitalization, and this is the temperature age distribution. So younger and elderly people are more vulnerable, and women a little bit more vulnerable than men. This is the same data disaggregated by socioeconomic status. Lack of education, poverty, income are important modifiers of the relative space. So the poorest are those that have more compromising health for less condition to treat their chronic conditions and also have value. Let's move a little bit more inside São Paulo. These are two neighborhoods or districts of São Paulo. Parelheiros at south, that's very close to the Atlantic coast, at south, high green coverage. This is Itaquera in the east zone, a desert of concrete and asphalt. Then you have this, how one reads this graphic. This is the lag, this is the change of temperature, this is the mortality 5 days before and 15 days before. In other words, temperature 10 days before how is related to mortality of 10 days afterwards. This is the minimum temperature. In Itaquera, hot waves are the problem. In Parelheiros, cold spells are the problem. So even for a given district, the solution is different. So health may be a moderator of global interventions and housing. And so there is a continental variability between countries, variability, between cities, variabilities different, and within cities, variability. This is the challenge. If you want to do urban interventions, you should know the local characteristics of this. So this is the national fall in money. This is a way of productive years adjusted, lost because of abnormal temperature, always. But so you have expressed in productive years, like due to precaution, to premature mortality. And this is the temperature across Brazil. And then you have the average productivity rice box. In the Amazon, is this. You have a problem that you have few people, so the productivity adjusted multiplied by results also in population, in the density of population. And this is a paper showing that this varies with country by country. When you compute national, what are the countries? Africa is not represented because of low data. But you see that there are countries that are more, let's say, the climate is more affected because of recent climate. Let's go to population. This is the view of my balcony in a polluted in São Paulo. And then this is a land of non-smokers observed at dogs. Unobserved. So we smoke a little bit without voice. This is just to show within micro-regional extent. In front of a medical school, there is a cemetery. And behind, there's a hospital. So the medical school connects to settings, the hospital to cemetery. So our job. And then you have zero, there is a large avenue in front. Here is the cemetery, which has 400 meters. And we measure the NO2 levels across various distance from the sun. Because in the cemetery, there's no track, there's material. And then you have the street that's assigned medical school. So the more you are in the track, the more you get on purpose. So one of the important things is not local pollution, but the time spent in traffic is important that of those. And you can quantify this, integrate this black carbon area, and then you have a result of mismatch. These are the fixed stations of air pollution monitoring, and these are even each black dot is an autopsy case. And this is the socio-economical status. The red, more red, poorer. You have a mismatch between monitoring. You have more monitoring and pollution in the more developed areas, less pollution in the best privileged areas. And here is the difference between what is measured by the central, by the fixed station, and what is measured in the limits of those. This is called environmental mismatch, socioeconomic mismatch. So those that live in downtown or the more developed areas are attributed to receive a higher dose, but in fact they receive much less pollution. And this, so the poor get more pollution. This is directly related in times in fact. So the control for pollution also is also dependent on habitation, distribution, and low emission. Let's go more. This is an estimation of and a global estimation of mortality due to global wildfires. So with satellite, you can disentangle PM derived from by forest fires. You have a distant wavelength, and this is established as a so in the days of higher concentration, the average air pollution produced by wildfires is responsible for an increase of 2% double. So have a rapid risk for respiratory and for fractures. This is dose response in global perspectives between concentration of wildfire and the way it's taken. This is the distribution in Brazil of wildfires concentrated across the agricultural ring of Amazon. Where agriculture burns. And then you have the dose response in Brazil, which is a little bit higher than the rest of the world. So this is the loss attributed to wildfires that should be subtracted on the gains of agriculture to have like next levels. Again, distributed unevenly across the agricultural regions that learn forests to produce. What I told that, trying to say that for urban interventions, we need local interventions. I talked about one specific contribution that science, but there is a symmetry also in the population. The reduction of solutions is uncoupled from the possibilities and engagement of local populations. And one of the challenges is to build up solid policies that incorporate the adhesion of local population. And each solution has to incorporate the costs, but also I think that The incorporation of health consequences may be a agglutinator factor of a complex solution, and also can perhaps incorporating values to this question. Indeed, I think that health may be an instrument to provide, to amplify human rights and dignity, and replace these asymmetries as observed in this figure. Thank you very much indeed.